Hi, Andrea. Nice to see you. How are you?
Hi, Alex. I'm well. How are you?
Good, good. Thank you for making time today for our conversation, which is part of our podcast here, Build What Matters, where we try to connect with leaders that are bringing value to FQHCs, the Federal Qualified Health Centers that we work with. So we know that you work with Quick Fill RX, but you have a very extensive background in continuous glucose monitoring and working with patients that are diabetic and so on. So really this conversation today is to learn more about the work that you've done with that population. I think for most of us, we know maybe one too many folks that suffers from diabetes. But before we dive into that, Andrea, can you tell us a little bit about yourself, your background, how you got into this line of work, and just kind of how what led you to the work that you're doing today?
My name is Andrea Milton. I'm a registered dietitian and certified diabetes educator. I've been in the field for now over 25 years. One of my first rotations in school was at a hospital who had a diabetes care center, and then I transitioned quickly into diabetes as a career choice. I work with all types of individuals who have diabetes, so type 1 diabetes, type 2 diabetes, gestational diabetes, kids, general population, geriatric population, pregnant women, newly diagnosed individuals with diabetes. So it kind of runs the gamut in terms of the individuals that I see.
So you have and you continue to help these patients, right? All ages, different ages. You say you worked in hospitals as well. In the time that you've been doing this, which has been some time now, have you seen any patterns as you could say, hey, here's kind of like the two or three patterns that I always see in the patients, regardless of age? Does that even exist? Is there such a thing?
Well, I think number one, people failed to recognize that getting diagnosed with diabetes isn't just a physical diagnosis, it's a mental diagnosis as
Mm,
well. It's emotional. And so, no matter if it's someone who's diagnosed when they're pregnant, or the family of a young child, or someone with type 2 diabetes, it's a really emotional thing. And that doesn't change despite the technologies and all the changes. A lot of my job is helping people live with the emotional side of diabetes because it's very, very difficult.
that's interesting. I've never, my mom has diabetes. My dad passed, but he had diabetes. They never took insulin, but I never thought about that portion, right? The emotional, psychological part that someone goes through when they're diagnosed with diabetes. Is that so? You're saying that's obviously a common pattern. How do you help a patient when they're dealing with that? When they're getting diagnosed, I'm sure first of all it's a shocker to them, right? What are some of the ways that you help them?
So initially, you have to help people manage the physical part. So that's checking with the glucometer or wearing the continuous glucose monitor. In the beginning stages, let's say pre-diabetes, we might not be dealing with medication yet. We're dealing with diet, exercise, things to do with people's lifestyle, their stress, their sleep. And then, as if individuals need it, we move on to oral medication, insulin. So it really depends on where people are, but we've got to get that physical component handled so that people can get their glucose levels in certain ranges that make people safe. And then move into the emotional stuff because if people, a lot of times when I see individuals who've had diabetes for a long time, it's usually never a knowledge deficit. It's not that they they don't know what they're supposed to do. It's how do you achieve those? How do you practice eating well, being physically active every day, managing your stress, getting enough sleep? It's how do you achieve those things that you're supposed to do having quote unquote diabetes, but it's difficult. And so I try to help people with that physical part, of course, initially, but then work through the emotional stuff that comes along with diabetes so people can maintain the physical stuff.
Yeah,
So
that makes sense. So when you're talking about CGM, right? Most people may not know what CGM is, right? Continuous glucose monitoring. I actually had the opportunity to try one of those, and it wasn't. Thank God, knock on wood, I'm not diabetic, but we attended a conference. It was a health conference, and there was this company. Can't remember the name of it, but they said, "Hey, if you want to try this, use this code. We'll send it to you." And I have to say, it was shocking. First of all, I wasn't sure if I wanted to put it in my arm, but I did. Right, it
right.
wasn't as bad as I thought it was. And then, to me, it was exciting to be able to track and see what was happening, right? When you start to educate patients on CGM insulin pumps, tell us a little bit about what that journey is like, because I know what it was like for me, but it's different. It's obviously very different because I'm not diabetic. To me, it was more of a learning process. But for someone that is diabetic, what's that process like for them when they are trying CGM for the first time?
Right. So, I mean, I think everybody should be on a CGM. Pre-diabetes, type 2 diabetes, everybody should be on because they give you so much information. But we start with teaching them like the physical components of what is a sensor, setting up the app, setting up the receiver, setting parameters for their alerts. We don't want it to alert all the time, every time their blood sugar's high, because if people start to ignore alerts, then the sensor's kind of not doing its job, because you don't want people to start ignoring alerts. And then that's when, once they've got the understanding of how the actual sensor works and getting information, then we really dive into the components that cause the sensor to get a high reading or a low reading. So that's really when all the education for diet, for exercise, stress, sleep, medication all come into play. But really the hands-on component is where we start.
Now, what about the insulin pump? I've never seen one, heard of them, never used one. I'm assuming that's a lot more invasive and a lot more involved. Or walk us through that. Like, what is that like when someone's using an insulin pump?
So you can take insulin from an injection or you can inhale insulin. What the insulin pump does, it puts the insulin in one of the pump systems and it is attached to some type of like a computer in the pump. And you program this computer to deliver insulin at certain rates and have different settings. And so the patient will wear an insulin pump, usually for most companies, about 3 days. You're wearing an infusion set, which infuses the insulin in the insulin, and you're controlling that amount of insulin through an app on your phone
Okay.
or an actual pump that's a little machine, and you can much better manage your blood sugar versus giving injections, because these pumps that are computers, they're automated, and if people have the resources, they link to the continuous glucose monitor that feeds them the information on how much insulin you'll be getting.
So the
So
CGM is CGM is telling the insulin pump how much insulin to provide.
well, it's giving the glucose number, and then the pump is deciding based on the settings that the doctor has
Got
prescribed.
it.
Should I give you more insulin, less insulin? How much should I give here based on that glucose reading from the sensor?
Wow.
They're
It's almost like
really
having a provider with you at all times.
Well, they'll call it like your artificial pancreas, like your pretend, because it's acting like a pancreas delivering insulin more naturally than an injection would do, because it's not this big amount of insulin. They're not, you'll hear that the loop isn't closed. The user still has to give a lot of input and make decisions. But yes, it is, the pumps have come so far with the advances in the continuous glucose monitors that it makes having to take insulin easier. Not easy, but easier
Right.
in terms of glucose management.
So what about the scenario? Because it sounds complex, right? There's a lot going on there. So what about a scenario where a patient has never been on CGM, doesn't have an insulin pump? All of a sudden, this is prescribed to the patient. The patient gets a hold of it through their provider or their pharmacy. But what if they don't have that support, that ongoing support from the provider or a care coordinator? What happens? Is it a requirement that there's ongoing support for that patient?
Well, there's not, I mean, if a patient doesn't have support, they are not going to be successful. That's guaranteed. The mandatory part, I don't know about. But I do know in typical hospital settings in physician's offices, a lot of people go on I do the trainings I've worked for different pump companies, and I do the trainings, and people who get support do so much better than people who don't get support, because they know how to use the technology. They understand how to keep themselves safe. If a doctor just prescribes it and doesn't offer support back to the patient, whether they're seeing a diabetes educator or the physician themselves does the education, patients usually aren't successful. And they usually end up stopping the technology because they're not benefiting from it, and they're very costly systems. So I see a lot of people who see, I have a private practice as well as work for different in situations, but people who are prescribed these devices, they just don't know enough about them to like get the as much information and get all the benefits out of them, and then they end up coming off of the systems.
So it could be lack of education. It could also be pretty intimidating. Am I doing it right? Am I not doing it right? Or, I could see how that could be pretty intense.
And interpreting the data. So these pump companies give you this wealth of data attached to your insulin pump, and you need someone to help you figure this out. Like, are my settings correct? Am I wearing infusion sets properly? Are my CGM alerts set accordingly? What do I do when I need to go exercise? Or people have all these different scenarios that aren't explained necessarily in the technical book. So they need support on how to figure out all different situations, because diabetes is 24/7. It affects every single aspect of your life. Everything. Diabetes touches everything about somebody's life. And so people don't just turn off their diabetes. They need to know what to do in different situations all the time.
So do you see other gaps that are happening where someone could be on CGM, but they're just not using it? Like, are there other things that are happening? Is it because I'm assuming, right? I know when I had it, even though it was for only, I don't know, I think it worked for like 3 or 4 weeks. It's a little maybe embarrassing to be seen with this thing on your arm, right? But what are some of the other things that maybe you've seen from some of these patients are on CGM?
Well, I think the biggest barrier to CGM is cost. They're very expensive, and if people can't get it through their insurance companies, people aren't wearing them. So that's the first thing. And if people lose their health insurance, they lose the ability to wear CGM. So cost is to me, the biggest barrier to people using CGMs. Next, I find is fear. People don't want to see their blood sugars go up after eating because they're fearful they can't have that food anymore. They don't want to be told that they don't want, there's so much shame and guilt that goes with diabetes because people are looking at what you're eating and are you exercising? And people just don't want that kind of scrutiny into themselves. And so I find a lot of people just don't wear them because they don't want the feedback either right there in the moment when they see their glucose level go up after, your blood sugars are high, you're non-compliant, you need to do something different. People don't want that feedback. It's embarrassing, it's shameful, and there's a lot of guilt attached to that.
I can see that. I remember when I took it, I was told, eat your protein first, eat your carbs after, right? Because that usually balance things out. And sure enough, like at least I noticed it. Like if I would eat my carbs first, my numbers will shoot up. But if I did it the reverse, and it was almost like if I was getting reprimanded if I ate my carbs first immediately, right?
Right. And you wore it for maybe a week or so. People live with
Right,
it for the rest of their lives, and
right.
you go to a birthday party and have a piece of birthday cake. Like, what protein are you eating first? You're just having a piece of birthday cake.
Yeah, no, that's true. Um, so for patients that are in CGM that are maybe part of a federal qualified health center, and I don't know if this has been your case, but when it's being managed properly and when the proper support is there, what does that look like in the life of a patient?
Well, the standard that we go for in CGMs, there's a term, it's called time and range. And so we're trying to keep people with diabetes in a certain time and range, which it's a national standard that's set between about 70% of the time. If you can be within this range, what they'll say is that's where you're going to be the most safe.
Lisa?
So keeping people in these ranges keep people safe. And so that's kind of what we're trying to, and we work toward what people are eating, or are they exercising, or how are they managing their stress, or are they on enough medication, whether it's not the new, but the GLP-1s or the oral medication or the insulin, trying to balance those things so their time and range is greater, meaning their glucose levels are in a better range where they're safer from having high blood sugars that can cause, complications over time, or low blood sugars, which are very dangerous immediately.
So those are the time and range is what it's.
Time and range is what we're looking for on CGMs. And so as a provider, it's one of the things I'll talk to people about is I don't want to be the only thing that they feel that like they're they're human beings first and they have diabetes, but we have to look at these certain metrics to know if what people are doing are working to keep them safe.
That makes sense. From the time you've been doing this and helping patients, has there been, maybe what has been some of the most shocking things that you've seen as a result of CGM or even insulin pumps where a patient had a positive turnout where they probably wouldn't have had that had those technologies and hardwares not been in place?
Well, I think for me, one of the biggest benefits of the continuous glucose monitors of CGMs is the prevention of low blood sugars. So before CGMs, you had to have symptoms
Mm,
like your blood sugar was going down. So the symptoms of low blood sugars the person would have to have them. And then they would do a finger stick and then they would get a number and then they would say, oh, I'm low. Well, these CGMs now give you information before you go low. So you can get an alert before you end up low. And so one of the biggest benefits I think for the CGMs are the prevention of low blood sugars, which does allow people on the other end of to bring high blood sugars down because it's safer to be closer to the time and range because you can prevent the low blood sugars. People used to just because low blood sugars are so dangerous, people would just leave their blood sugars incredibly high so they never went low, but that sets you up for the long-term complications. Now with the sensors, because we have so much information so much faster, you can really bring your sugars down and get more time and range with reduction in low blood sugars.
I never thought about that portion of it, right? Because it's always like making sure it's not too high, right? It's always like making sure your sugar level is not too high.
Right, right. And definitely that's something we look at. But to me, that ability, the changes that CGMs have made are really in helping people bring those high numbers down because we can reduce the risk of low blood sugars at the same time.
Got it. Got it. So in California, our understanding is CGM is, if not 100%, primarily mostly covered by Medi-Cal. So if you have Medi-Cal, you get prescribed the CGM. It's 100% covered by Medi-Cal. You as a patient don't have any out of pocket. That's one of the many benefits that we understand in California. But let's say someone gets CGM, they got it, and let's say it's a patient that you're working with, or just in the history that you've seen of working with patients with diabetes and they have CGM, what are some of the things that they're constantly asking for that they wish they had that maybe they don't have, right? Is there something that you continuously see from patients asking for certain things that maybe are not provided to them?
I mean, if insurance is going to provide the sensors, something that they are not receiving. I mean, me personally, I think anybody on a CGM should meet with a diabetes educator to interpret this and understand what they're seeing and what's happening. A lot of people get very afraid of wearing sensors because they don't want to know the results, but working with someone to help interpret that. So,
Yeah.
in terms of what's missing, I think people with diabetes, I think diabetes education is so under provided in this country.
I remember going to a class once with my parents, and it wasn't about diabetes, it was about healthy eating, right? And I was like just sitting there. And I remember the class was full, it was like 30, 40 people. And I remember walking out of that class and my both of my parents saying, "Why didn't anyone ever tell us that?" Right? Like, what why didn't we know that before, right? Because it's just in a lot of our cultures, we're not taught those things. No one really talks about them.
Right. And insurance companies only pay for education to see a dietitian, because that's what I do, once you've got diabetes.
Right.
So Medicare will not pay for education if you're overweight or you're obese or you have prediabetes. You actually have to wait to get the diagnosis of diabetes in order for Medicare to pay for it. And a lot of the insurance companies, they follow the Medicare guidelines. And so our culture does not value eating well and having highly nutritious food available. So a lot of people just don't know and understand. And I'll hear a lot of buzzwords like, well, I eat healthy. How did I get diabetes? Or I eat clean. And those things don't necessarily help you prevent getting diabetes necessarily. So there's a lot of nutrition education that needs to be had.
Well, Andrea, we appreciate the work that you're doing. That it's important work. I wish more people for doing your work. I wish more of us had access to someone like yourself. I know it could be intimidating for people, especially when it comes to our health. We sometimes rather not know, and it's easier to just pretend you don't know. But thank you for the work that you're doing. Is there anything else that you would like to share with our audience? You know, either around the work that you do or any recommendations for any of us, right? Maybe for folks that do have diabetes, some of us that fortunately don't, or maybe some pre-diabetics. Anything you would like to share?
I think that the key to managing diabetes is through education, whether it's for education for the physical component or whether it's getting education and seeking out mental health resources for diabetes. Because I do believe that a lot of people who have diabetes should be getting mental health resources and they don't. And I think that leads to a lot of, which is not my term, but I think it leads to a lot of people who are non compliant, but people who aren't accessing care from fear, shame, guilt, all that kind of stuff. So I really think education is the key.
Thank you for sharing that, and thank you for the work that you're doing. I want to close out that you said something that I wasn't expecting, which was it's a mental um, behavioral challenge as well for patients that have diabetes. And I will say that one of our partners that specializes in behavioral health, they've tracked it and they've actually seen how the patients that are being treated for behavioral health, their diabetes has improved. And
Absolutely.
to hear you say that, it confirms a lot of what they're seeing in their stats.
Definitely.
Andrea, thank you so much. Thank you for your time. We really appreciate it.
You're welcome, Alex. Nice to meet you.